Good morning. I'd like to welcome you all to our next sessions, due to be in here till 12:30, till lunch. I'm Ria, I'm chair for this session. We're starting off with the sessions. These are all based on skincare and dermatology, and I'd like to invite onto the stage Richard, who's going to talk with us about dermatology and skin.
I'm basically a dermatologist who works at 2 hospitals, and I also work for Accelerate doing my wound care bit. And it's quite hard to teach in half an hour, you know, what I've learned over 20 years. But what I thought I would do is cover how we approach the skin as a dermatologist, and cover some of the very common conditions that you probably will associate with patients who've come in with wounds, may also have a skin disease. And then there's things which overlap, where the dermatology overlaps with wound care. So to start with, dermatology is like any bit of medicine, and it's all in the history examination, and in our state, very much a lesser extent, investigation. And I find it quite interesting. When I started in dermatology, it was really imposed very clearly on us. You had to palpate the skin. You had to feel the skin. And of course, in those days, we didn't have gloves everywhere. And I find it quite odd that I have my juniors who will put gloves on at the drop of a hat. And to me, that doesn't quite fit in with my concept. I was told that you actually were making a barrier and making the patient feel as though they were dirty if they had a skin disease. So I still think it's, remains part of the care and important. Okay. Now, trying to keep it simple, there's only really 4 basic pathological processes that you ever have to think of that goes wrong in the skin or in any organ. One is degenerative, and in fact, degenerative really doesn't affect the skin until you get over 80, 85. So if you've seen those very elderly people, you just see that really fragile skin. So that's classic age-related degeneration. So the main ones we have are infection, inflammation, and neoplastic, both benign and malignant. So there's sort of 3 processes we think of. And then when you come to the skin, there's 3 main layers. You've got the epidermis, which is your waterproof outer layer. You've got your dermis, which is the structural layer that contains most of the organs that we know of, like sweat glands, blood vessels. And then you have the subcutaneous, which is the fat. So any of those layers can be affected by a process. And so in a way, what you come to, any condition can be put in one of 9 boxes. And you probably, if you've ever had interaction with dermatologists, they come in and they walk out and say it's X, and you think, they've just looked at it very quickly. And it's true, because that's pattern recognition. You've looked at so many, you've done it. But if you get at something difficult, we all have to resort back to this. We have to go back to our basic observational skills and think about what pathological process could be going on and what layer. And that will then help us think about what conditions it may be. And I've included, I think infection is a really interesting one, because I teach the medical students. So just take streptococcus or staphylococcus. On the surface, it gives you impetigo. Now, I bet your kids have had impetigo. Nothing to worry about. Treat it. That's fine. You might even get away with topical. Then you get erysipelas, which is the upper dermis. Then you get cellulitis. And then obviously, it can give you necrotizing fasciitis if it's really deep. And that's a really serious condition. But it's the same bug. It's just that depending on what level the pathology is lying. And that also explains, depending on where the pathology lies, how easy is it to see the signs. And I'll come on to that. Right. Our basic, when we're looking at the skin, you start with distribution, and it's the overall distribution. And if something is symmetrical, then that means it's come from inside. So we often say endogenous. If it's asymmetric, you may well consider it to be exogenous or for something outside. So up in the top left there, is classic shingles, and that's and that would count. Although it is endogenous, it is exogenous. So what we do, look at distribution, symmetry, and then you might look at the particular lesions that are composed of, and do they have any grouping? So are they in a cluster? Are they lots of them coalescing? Are they in a straight line? Dermatology doesn't do very many straight lines, but there is something called lichen striatus, which gives you a patch of eczema in a very straight line down the arm or the leg. And you see it in kids, actually you can see it in adults. And then you might look at the nature of the individual lesion. So that's how we're classically trained. So really, the surface that, when you see signs on the skin, they're usually because of the epidermal changes. All right? So the things that you can see, I've put on your right, the crusting, hyperkeratosis, erosion, and I'll show you some examples. You can get blisters in the top layers of the skin. That's very much a pattern of eczema. And you can have thinning, or you can have pigmentary disturbance. Now, your pigment cells lie at the dermoepidermal junction. So anything which interrupts that can lead to changes in your pigmentation. So that's why scars are often changes, because that's, if you have an ulcer, that's you've broken right through. Before I move on to sort of things, you have to, skin biopsy, which is often what you think, well, you might need to do more often, isn't always as helpful as you want it to be. And if your eyes don't tell you a good story, then the pathologist may not be able to do any better than you. Not always the case, but often the case. And the other thing to remember is that your pathologist will often need to interact with your clinician to get a sensible answer. So if I, as a clinician, throw in some suggestion, which may even be a bit wayward, the pathologist may agree with it, although it's not clear-cut. It's because I've led the way, I've biased it. So you have to be careful. So what's his real help is diagnosis of malignancy, and I think that's, the general teaching that if you have an ulcer that's going on longer than sort of 6 to 12 weeks and not changing, then think about a biopsy to exclude malignancy. Autoimmune blistering disorders, very diagnostic there, and vasculitis is something that often helps. Okay, so these are just some sort of physical signs to show. So this is the highlight that actually the changes are in the epidermis. So I put there, when you lose your top layers of your skin, you get an erosion. Quite easy to be confused with ulceration. But notice a lot of hyperkeratosis around. So that is classic eczema. This was referred as a leg ulcer. So look for erosion. It's a smooth red appearance. If your granulation tissue is eggshells, bumpy. Crusting, this is impetigo there, so crusting. In the middle here, when you thicken up your skin, that's called lichenification. So what you're actually seeing there, do you see the creases? That's where you get prominent, the very fine dermal creases that you have in your skin get accentuated due to thickening in the epidermis. And that is due to scratching. Blister, and then actually a straight break from excoriation. So, eczema takes many forms. The basic process in eczema can be split into two forms, acute and chronic. Now, acute is that you get little blisters in the top layers of the skin. That's why you can get oozing and crusting. I don't know if you've got kids with eczema, but it can sort of really break down quite quickly. So and that would be, acute eczema is also known as wet eczema. And we often see that on the legs in people with bad gravitational dermatitis. And you can see it with atopic. Here's more one with just scaling. And then I've put here an example of asteatotic or dryness. So that's just to remind you that really in eczema there's two components. There's dryness and there's inflammation. Hence our treatments. And I've shown you the erosion and hyperkeratosis. There's more examples. And that's, I think, a pretty classic example of eczema on the legs, a mixture of hyperkeratosis and eroded areas. Now, it can also take other forms, and I'm going to come back to this, but this is just another example of what you can get with hyperkeratosis. Now, the way your skin is maturing at a certain rate, so it's programmed to lose the top layers, the keratin layer, which is in fact dead. So you're programmed to lose at a certain rate. That can get disrupted. So if the keratin stays more sticky, you end up with this sort of pattern of these sort of, in effect, layers of, I mean, it's dead protein just sitting there. And then that acts like a waterproof bag. So it's useless putting your creams on it because it just sits on it. And that's why you're always taught about skin toiletry to get to it. And actually this also highlights that actually when you take it off, you often get the eroded areas. Contact, funny patterns, think of contact. When I started in wound care, contact dermatitis was a big issue. I mean, I think 20% of patients attending chronic leg ulcer clinics would have had a positive patch test. And the common ones then were perfumes, a lot of products used with perfumes in it, parabens, and topical antibiotics were the mainstay. I've now hardly referring now for patch tests because I've just seen those chronic eczemas just gone because of better care and better choice. I mean, it's just interesting now that we've lost Steripaste, we may see more back to the parabens coming back in because of Viscopaste and Exapaste as the only paste bandages we have. And the other group I'm going to raise again is you can be allergic to steroids, so it's worth remembering that. This one, you'd worry about rubber. Now, a funny eczema, it's got a posh name. It was described by a couple of dermatologists in Bristol 20 years ago. And you see it in elderly scalps. And what they get is a crust on top of their scalp, and you take it off, and it's all not frank pus, but a sort of little smear and eroded area. And it got given the term of erosive pustular dermatosis. And it's quite hard to sometimes differentiate from skin cancer. I don't know, has anyone ever had to treat any as a call to see? No, yeah. Sometimes it's missed, and actually, but it responds to cleaning and topical steroids. So you put a potent topical steroid, in fact, Dermavate, and it clears. Well, you see something similar in the legs. I think it's just a pattern of eczema in chronically damaged legs. But the fact is, often it goes back to that you get, these aren't as good examples you sometimes see, but there's often that you peel off they almost look like a pustule, and you take it off, and it's red raw underneath it. And it's a form of eczema, and treat it as such. But you've got to take off the dead bit to get the steroid to work. Interestingly, some of those you need to do a sort of once weekly application of steroids just to keep it at bay. See, it's interesting, it's not in the textbooks as such, but quite a few people with chronic atopic eczema will do a once a week treatment or a 5-2, so they'll do 2 days a week treatment with quite a potent topical steroid on relatively normal skin to stop flares. And it's something they've learned that actually works, not to be approved of, but is effective. Okay, another one that sometimes crosses over, and I'm sure you have this sometimes, it's the Lichen simplex. Now, this is just somewhere where you get itchy skin, and then it just it stays itchy, and you scratch it. So you get an itch, scratch, itch cycle. Commonly elbows, nape of neck, and legs are quite commonly. And I've included in also there somebody with sort of just chronic itch, prurigo, and they'll just get thickened areas. As with many other things that we treat, topical steroids, but the important thing here is occlusion, is to break the itch, scratch, itch cycle. And they sometimes come up to leg ulcer clinics, I think, because they just don't know what to do with them, but they do well with occlusion. Now, it's always, you see, the names always get, now we've got lichen planus, it's got lichen simplex, lichen planus, completely different condition. This is an inflammation, relatively rare, and it gives you itchy spots. They're supposed to be a particular purple violaceous colour, and you get mouth lesions. I've not had one referred in as a sort of misconstrued as a leg ulcer, because usually they've got it quite widespread. But it's one of those conditions with very itchy, and you have to use potent topical steroids and sometimes oral steroids to control. Does anyone know what that sign is? When you get a skin eruption coming up at a sign of trauma, where scratching, it's called Kerbner, and it's seen in psoriasis. And also seen in Lichen planus. It's viral wart, so it helps us make so that's Kerbner there. Psoriasis is one of those ones which doesn't really present to leg ulcers, but actually complicates patients with leg ulcers or other pressure ulcers. Per se, you know, you'd recognize a red scaly plaque. They are classic ones. Here, you've got ones which show a little bit more of what happens. This bit more inflammatory, and you can get back to that sort of eroded appearance in places. And I think this is a pattern that you might often see if you've occluded legs. You get this very eroded, and this is what you see in the flexures. So again, it's something you might see for people with pressure ulcers around that sort of site. So you lose all the scale, and you just get that red raw area. Treatment now, you see, of course, there's quite a few options here, but mainly it's topical treatments with vitamin D analogues. But then if they're bad enough, then they go phototherapy and on. And now our number of drugs we've got has increased with biologics, so we have all the things like cyclosporine and methotrexate, and then we can move on to the biologics if needs be. So I think the life of a psoriatic has changed quite a lot since the singing detective time. So, but the flexural, that needs topical steroids. Now again, that was one we would often use. We often would use Trimovate cream, and that's one of those products that comes and goes, depending on, I think it's back available. Or in the old days, we'd have used tar mixed up with steroids, but we find very difficult to find the mixtures being made up now, so we have to stick with off the shelf. Has anybody had to have bullous pemphigoid patients look after? Okay, now this is a disease of the older person, rare before the age of 60, does happen occasionally, more in the sort of 70s, and what you get is these clear filled blisters on a red background. Usually, classically, it's said to be bunches of grapes in the sort of groin and axilla, but it can be all over. It's where the body's made antibodies against the basement membrane. So you get a split between the epidermis and the dermis, and that's why you get tense blisters. We've just done a multi-center trial looking as to see whether it was topical steroids, it was actually oral steroids versus an antibiotic, and what effect on the treatment, and it wasn't clear cut. So if you localize the disease, you can get away with topical treatment. If it's systemic, then you have to give oral steroids with or without the tetracycline. I'm not going to talk much about skin malignancy. It is important on the leg to think of, I put a normal BCC in here, but you can't tell always on the leg of a leg ulcer if it's a BCC or not, so often you need a biopsy. STC. What I would point out, I put a standard melanoma in here, but we've had several cases where non-healing warts or funny ulcers under podiatrists have come through, and they can be an amelanotic melanoma. So I think there's caution. It's not always the podiatrists don't always recognise, because it does look funny. So I think lesions that stay on the feet need to be assessed by somebody. And the other one we've had recently, and just a reminder, is you can get it, and this is, if you get bruising that doesn't clear. And this is the angiosarcoma, so that's a malignant growth from blood vessels. Very rare, but it's when you get persistent bruising on say on the leg or the scalp that doesn't seem to go after prime time, then that needs to be biopsied. This is obviously looks like a tumour now because you've got nodules, but it can just, as I said, look like bruising. Okay, all things that are round are not all tinea, but do have to think of it. Classic tinea is a ring and you get central clearing. So that's a diagnosis. And you get superficial scale. What I've included in here is heat of bandages, you get an increased risk of tinea. So think of that. If you are going to do, it's worth doing skin scrapings. If you're going to learn how to do it, it's worth remembering that you need to degrease, because if you've been a good carer and you've greased the leg up, actually the grease stops it growing. So you have to put an alcohol wipe on it before you do the scrapings. It's true for the doctors to do it, but I'm not sure many GPs know how to do it. And treatment is, if you can see it, is 2 weeks of antifungal agents, and it's quite effective now. I'm just going. There's a condition known as tinea incognito. It's a very odd name to say tinea unknown, when in fact what it is fungal infection when you've used a topical steroid, which has made it worse. And that's, so if a rash suddenly worsens after, you think it's eczema, you put a steroid in, it's suddenly worse, think about tinea. Now this is an old nugget. Is all interdigital maceration tinea? I don't think so, but I often have arguments. I think quite often it's eczema. And it's just a matter of cleaning carefully between the toes with a moisturising cream and also using a topical steroid. That, if there's obvious tinea elsewhere and you've scraped it, they do it as well, but I think it's often poorly treated. So I'm just going to talk a little bit about steroids and my take on topical treatments. There's a lot, I think there's some dogma here that is probably correct, but actually in the real world, do we have the time and does your patient have the time to do it? So the standard thing is, emollients first, wait half an hour and then put your topical steroid on. I don't know many patients who do that. And if you think about it, it depends a little bit on in what form you're putting your steroid on in. If you are doing it in a grease, in a sort of oily grease, in effect what happens is your drug sits there and goes in via a concentration gradient. So as long as you can leave whatever's there long enough to go in, it doesn't matter which one you put on first because it all mixes in. The difficulty, of course, is if you put a lot of grease in and then you put clothing on, then it all just wipes off very quickly. So often something is, how do you keep it in place longer? You can cover it with cling film with something, or just get the patient to sit quietly for a while just to let it soak in. I tend to do just once a day for application. Cochrane review in kids in eczema once a day is absolutely sufficient. Moisturizers, different formulations. The more greasy ones tend to work better for trying to rehydrate the skin, but again, in that case, down to patient preference. And it's worth remembering that all the creams and lotions have preservatives which you can react to. The other thing you might come across is somebody who says, every cream I use I can't cope with, and they're known as stingers, and you just have to coax them into finding one that suits them, just say it's not their fault, just ease them into it, and usually they can find one that works. Potassium permanganate, depends on where you speak. I've got colleagues who'll use it on legs far too long, but it's a very good drying and antibacterial agent used sensibly. 2 to 3, if you've got a really wet leg or really wet leg ulcer, 2 to 3 applications and then you've done and you can get on. And you can either do it soak in a bucket or gauze swabs. It's a practical way to drying up something. And then it gives you time for your compression to work. Now, some important points on topical steroids. A lot of confusion on here. There's 4 groups, and you can look them up in the BNF, all right? Mild down to very potent. They're based on a bit where they put them on the skin and see how white it goes. What happens is you look on there and you'll see 0.05, one's 0.05% and one's 0.01 and 0.1. They're actual different chemicals, so forget the concentrations. Look at the class that's in the BNF. And most of them are in the strong. There's a few very strong and a few weak and a few moderate. All right? So that's important. Look at class, not concentration. Quite often, how much, and how often? I tend to come around to, if I get an itchy rash, I'm going to slap them on because I want to get better quicker. And that's probably the best way of using them. Short, sharp bursts. I've not seen problems with atrophy on the legs, because often you're only putting it on once or twice a week. So again, I would suggest put enough to make the skin feel greasy. And I've been quoted before about just look out for tinea and hypersensitivity. So I suppose what I would stress is you've got to have a diagnosis. Investigations don't rely on them too much. Treatment is, we have effective topical treatments for many conditions. It's often not always easy for the patient to follow them, but if you do, you stand a good chance of having reasonable control. And topical steroids remain a really important treatment that makes my life easier. Okay, thank you.
We've got a time for a few questions, if anybody's got any questions for Richard. Nikki? Wait there.
Where's a big ball?
Watch your head.
What was it?
Hi Richard, that was really interesting, thank you. In clinical practice we're starting to see what I think is erosive pustular dermatosis occurring under compression much more frequently than we used to see it. Any reason for that?
Yes, it's an interesting because one of the original observations on the legs was done by a chap named Sean Lanigan, who reported up in Harrogate BAD in about 1988. And he was completely shot down by the dermatologist. He was talking a load of rubbish. But when you start looking, it's there. And, it may be something to do with long-term occlusion plays a part. I don't know. I think it's an argument. Anybody who's been in long-term compression for that long, it's wrong. We've got treatment wrong. So we should be finding ways of controlling. I also think there sometimes might be, we've used steroids and that might even make it, sometimes they get a sort of rebound effect. It's a difficult one, but it does, in the end, it responds to topical steroids.
Yeah, it does. Yeah, thank you.
Any other questions? Thank you, Richard. Thank you.